Okay, let's go ahead and get started. Welcome, everybody. I'm Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us for the HTRC Education Series focused on telehealth billing, coding, and policy. Just a few notes for all of you. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted. Please unmute or use the chat box to talk. We will be monitoring that as well. Your completion certificates will be emailed shortly following the webinar. It's important to sign on with your first and last name so we can identify you. Please rename yourself by using the 3 dots on your Zoom screen if your full name isn't visible. We will be monitoring the chat for questions. We will be saving the questions so we can address them should we run out of time today. In the past, we have created a question and answer resource form to share following the webinar. So we will do this if a lot of questions come in today. So let's get started. I'd like to introduce Rochelle Martin. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have Rochelle with us today to talk about updates for the new year, this year 2023, legislation that extended certain flexibilities, and important dates related to the end of the public health emergency. Now, I'll turn it over to Rochelle.
All right, thank you, Molly. Well, when we scheduled this session, my intent was to talk about some legislation that happened in December that took some of the public health flexibilities, public health emergency flexibilities related to telehealth that last year around March 29th, I think it was, had been extended through federal legislation for 151 days after the public health emergency ends. And this December of 2022, federal legislation took those flexibilities and extended out even further. So my intent was to talk about that federal legislation, talk about it in light of last year's Medicare physician fee schedule final rule and what that might look like when the public health emergency ends. In the interim, we've had even another exciting development. Exciting, I guess, would be the optimistic way to look at it. That the Secretary of the Federal Department of Health and Human Services has announced their intent, as we stand today, to let the federal public health emergency for COVID-19 end, with the intent that that would become effective May 11th of 2023. With that announcement, if it does in fact expire on May 11th, 2023, we now have some more solid dates and timeframes to work from. Then we can start talking about what happens with the federal public health emergency and when. So that's our big late breaking news that I always like to start the sessions with. What's the newest, latest, and greatest in telehealth policy? And the announcement from the federal Secretary of the Department of Health and Human Services was that big announcement. So this came out just January 30th. It's only been 8 days, so it feels like breaking news, although many of you have already heard of the news probably. When we send the slides out, you'll have the link to the official announcement from the Secretary's office, and we'll kind of talk about some of the pieces of this resolution and what it means. But in the big picture, a couple of things that it means are flexibilities that the agencies like the Department of Health and Human Services, CMS, Medicare and Medicaid Services, the Office for Civil Rights that enforces HIPAA, the flexibilities that they were able to make only because there was a federal public health emergency that broadens their authority as government agencies will go away. And so those flexibilities that could only happen as a result of the public health emergency will go away. And then there's a whole bucket of flexibilities that the agencies have the authority to change through their rulemaking process independent of the federal public health emergency. So we're going to take a look at what some of those requirements are and some of the timeframes now as we get into sort of the wind down phase. And I'm going to say knock on wood, because even though we've got this announcement, something could potentially change still between now and May 11th of 2023. But here are some important dates we need to keep in mind. We, of course, have May 11th, 2023. And I want to keep in mind, too, that this is the date that the secretary said the public health emergency will be allowed to expire. Guidance that I anticipate will be forthcoming will be, does that mean midnight on May 10th? Meaning going into May 11th, or is it the end of the day on May 11th? So we'll get some more details like that as we get closer to the date. But with that date, there are certain telehealth flexibilities that will go away the day that the federal COVID-19 public health emergency ends. So we're going to spend a little bit of time this afternoon talking about which of those flexibilities we know today will go away on May 11th, or when the PHE ends. December 31st of 2023 is another important date. There are more telehealth flexibilities that through rulemaking, the Centers for Medicare and Medicaid Services indicated would continue, but only through the end of the calendar year when the public health emergency ends. Now that we have that date, that anticipated date of when the COVID-19 federal PHE will end, we now know that 2023 will be the end of some of those flexibilities, unless something changes between now and the end of the year. And then December 31st of 2024 is another important date when another bucket of telehealth flexibilities will continue. So I'm going to talk about each of those time frame buckets to give you a sense of some of the important telehealth flexibilities that have come about as a result of the COVID-19 PHE, and which of those buckets they fall into in terms of when they go away, if they go away, because we have some that are going to stick around even on a permanent basis. So I think the very most important things to keep in mind are what's going to change the day that the PHE ends, because we have gotten so accustomed to some of these processes and some of these flexibilities and practices over the last 3 years, right? Last 3 years at this point, that this may be a considerable reversal for some practice areas and some organizations. The first of those, and let me back up just a moment to talk about what things looked like before the PHE for telehealth. The telehealth benefit under the Medicare program was rather restrictive. We have a list of services that are eligible to be rendered as telehealth services. That has expanded temporarily during the PHE. We had a list of distant site professionals who were eligible to render and bill for telehealth services. That has broadened during the federal public health emergency. We had a list of eligible originating sites, both a geographic location, a rural geographic area, that has broadened, making the patient's home an eligible originating site. We also had eligible healthcare locations where the patient could be located, a provider office, a critical access hospital, an FQHC and RHC, that have broadened during the federal public health emergency, among other things. So that was kind of our pre-COVID environment. One of those flexibilities during the federal public health emergency is to allow critical access hospitals to serve as distant site providers of telehealth services. And one of the ways we saw that being used during the federal public health emergency were critical access hospitals that could render certain outpatient services or therapy services to patients at home, since home became an eligible originating site during the PHE. Critical access hospitals prior to the PHE were not eligible to serve as distant site providers of telehealth services. It was only because of the public health emergency that the Department of Health and Human Services made that available. Now, the limitation on eligible distant site providers comes from the Social Security Act. And so it required an act of Congress, not a policy or a rule from the agency, to make that change. And in March of last year, the Consolidated Appropriations Act of 2022 extended certain telehealth flexibilities for 151 days after the PHE ends. But an important omission from that legislation was critical access hospitals serving as distant site providers. And there was legislation in December of 2022 that took many of those same flexibilities and extended them out even further. Critical access hospitals as distant site providers were not a piece of that legislation. So the day the PHE ends, critical access hospitals cannot serve as distant site providers of telehealth services. They can, as they always could prior to the PHE, continue to serve as eligible originating sites where the patient is located for a telehealth service. Another question I get quite a bit from this group is what happens with, it's called the Ryan-Haidt Act. It's from the DEA, or the Controlled Substances Laws and Regulations at a federal level, that say prior to prescribing a controlled substance via telemedicine, there has to be an in-person visit, not a face-to-face telehealth visit, a physical in-person visit before those controlled substances can be prescribed via telehealth. That is a statute that cannot be changed absent an act of Congress when the public health emergency goes away. So the day the PHE ends, the DEA's ability to waive that requirement ends. What we don't know, where the DEA does have some flexibility, is to talk about what happens to those patients who have been receiving telehealth services and having their prescriptions initially prescribed because of that flexibility during the PHE. And once the PHE is over, will they have to come back for an in-person visit to then return to telehealth prescribing of those controlled substances? Or will there be some sort of grandfathering provision if a patient's initial controlled substance script was issued as a result of a telehealth visit during the PHE, which normally wouldn't be allowed? Will that script continue to be able to be renewed or refilled after the PHE ends? So we don't have that guidance yet. But watch for that, because I know there will be a lot of questions about those patients who have been receiving telehealth services in the last 3 years during the PHE. There are some changes that will go away the day the PHE ends for remote physiologic monitoring, remote patient monitoring, and remote therapeutic monitoring. These are the services where they're not face-to-face, they're not truly telehealth, but they are things that are happening outside of a face-to-face or an in-person visit with a patient. Remote physiologic monitoring is when you have the patient have a device at home, like a scale, a digital scale, a blood pressure cuff, a pulse oximeter, where that device is able to digitally, automatically, and electronically transmit the readings back to the healthcare provider. So it's not input by the patient, it's the device sending those readings to the healthcare provider. And RTM, remote therapeutic monitoring, are more subjective patient input of their respiratory status, their functional status. So those services prior to the PHE could only be rendered to established patients. During the public health emergency, CMS opened the door up to allow those services to also be rendered to new patients, patients who have not been seen by the monitoring provider or another provider of the same specialty in the same group practice in the last 3 years. The day the PHE ends, if you're going to provide remote patient monitoring, whether it's physiologic or therapeutic monitoring, that can only be done for established patients. So you will have to establish the provider-patient relationship before you can begin the monitoring service. Now, that can be done a lot of ways. That doesn't necessarily mean there has to be a physical in-person visit before you start the monitoring service. Provider-patient relationships can be established via telehealth, but it has to be an established patient, the way that term is defined for coding and billing rules, to be able to bill RPM or RTM the day the PHE ends. And again, a question mark that we don't know is what about those patients who may have been maybe new patients after the PHE ends at some time during that month, or sort of that grandfathering clause on the transition right around the May 2023 timeframe. So we'll have to wait to get some guidance from CMS on how they will handle that. There's also been a flexibility during the public health emergency that if you are monitoring a patient for COVID-related symptoms, that the period of monitoring could be as few as 2 days in the month to be able to bill for remote physiologic monitoring. The typical coding requirement is that there are at least 16 days in the month of monitoring services. The day the PHE ends, that will go back to requiring 16 days. And I'll put kind of an asterisk on that again. If a patient starts that monitoring on May 10th or 11th for COVID-related symptoms, so they're in the middle of their monitoring when the PHE ends, we don't know yet if CMS is going to immediately revert to 16 days or say as long as the patient started their RPM for COVID-related symptoms while the PHE was in effect, you could still use the 2 days as opposed to 16 days. So more guidance is needed on those details. There's a guidance document. It's buried in a long-term care CMS flexibility document, but it extends beyond just long-term care organizations, and it deals with provider enrollment. During the public health emergency, we may have had providers rendering telehealth services outside of their normal practice locations. So if you think of the provider office as the normal practice location whose address is registered with Medicare on the 855 enrollment form, right? If the provider is rendering telehealth from their home regularly or other locations regularly, during the PHE, Medicare said you do not have to enroll the provider's home address as a practice location. And this long-term care facility guidance that I'll have a link to on the slides when they come out says that after the PHE ends, providers do need to enroll those alternate practice locations on their 855 enrollment. This one, I would put kind of a big red flag on that if you have providers performing their services outside of their normal practice locations, and you've been relying on this PHE flexibility to not enroll those additional practice locations with Medicare, this is something to start acting on as soon as possible, because we know those enrollments can take 30, 45, 60 days on a normal basis. And right now we've got a whole nation that's going to be scrambling to add practice locations by the May 11th deadline. So this is one that you don't want to wait. This would be sort of an immediate action item to see what types of Medicare enrollment forms need to be updated based on that guidance. And the last one, important one, the day the PHE ends, is that the Office for Civil Rights had issued some notices that it would use its discretion to waive enforcement of certain HIPAA violations. And I want to reiterate, again, we've talked about this several times over the last couple of years in these HTRC sessions. HIPAA has remained in effect for the entire duration of the PHE. Breaches, impermissible uses, and disclosures could still receive penalties during the entire PHE. The Office for Civil Rights is only one of several enforcement agencies, and it was the only one, unless your state attorney general or other enforcement groups also waived their enforcement discretion. And the enforcement discretion was very, very limited. There were a few pieces regarding how you administered the notice of privacy practices that if you didn't follow them with perfect I's dotted, T's crossed, OCR would waive enforcement action. But the big one at the beginning of the PHE was that if you were using a non-public facing platform to deliver your telehealth services, but it maybe wasn't up to all of the normal HIPAA security rule standards, that the Office for Civil Rights would waive their enforcement discretion for the use of those types of platforms. We've had 3 years now to adapt our telehealth services to platforms that would comply with the HIPAA security rule. So the day the PHE ends, if you've been using FaceTime on your iPhones or other platforms without a HIPAA secure subscription to them, that enforcement discretion, is going away the day the PHE ends.
Rochelle,
Okay.
I would like
Yes.
to address a few questions in the chat
Sure.
box. The first is with the Ryan Height Act. Does it end the exact date of the PHE, so May 11th, or does it fall into those grace period days?
Yeah, so that's a great question where I'll be looking for guidance from the Federal Department of Health and Human Services. When they say the PHE ends May 11th, I've got the same question. Does that mean May 11th is the first day without the PHE? Is that the last day of the PHE? So really we're looking at May 10th, 11th, or 12th. Which day is it that all of the pre-PHE rules will come back into effect? And we don't have that guidance yet. The second part of that question about the grandfathering provision, we don't have that guidance from DEA yet either. So the most stringent interpretation or requirement could be the day that the PHE is no longer in effect, you could not prescribe a controlled substance via telehealth if the patient had not had an in-person visit with that provider before that script started. And for patients whose script commenced during the PHE, during a telehealth service without an in-person visit, the very most conservative interpretation would say they would have to come back in for a face-to-face in-person visit before you could refill that script. I don't know if that's the way the DEA will interpret it, or if they will issue some sort of grandfathering provision where patients who have been receiving their controlled substance script during the PHE maybe could be grandfathered in, and only new meds, only new patients would require an in-person visit. So that guidance is still pending, and it's a great question because we don't know exactly how the DEA will handle it.
And I think your response leads to the second question about Ryan Height, in that if a patient is established in our office and has been seen in person, can they be prescribed controlled substances since they've had in-person visits previously? Or does that original prescription have to be from an in-office and refills telemed?
Okay, so that's a great question, and that gets right to the core of what the Ryan Height Act is and does. It says that you can't write scripts for controlled substances via telehealth unless you have an in-person visit with that patient first. So I may need a little bit more details on this scenario, but what I'm hearing, what it sounds like is the clinic has an established provider relationship with the patient that at least at some point in that relationship, there was an in-person visit prior to prescribing a controlled substance via telehealth. And if that's what you've done, then you've met the requirements of the Ryan Height Act. And when the PHE goes away, you would have still met those requirements. Really where the I wouldn't say concern, but the question or the gray area will come into effect is if there had not been an in-person visit first, before you had a telehealth visit where controlled substance was prescribed.
And if that doesn't get to the core of your question, Jen, you can message me and we'll work on that after the webinar as well. Another question is about provider location. So is the practice location applicable only to Medicare and Medicaid? In other words, not applicable to commercial insured patients?
Yeah, it's a great question. And I don't know that Medicare, Medicaid, or any of the commercial payers have given a lot of thought to this, but another thing to keep in mind, if you've got providers who will enroll their practice location, let's say it's their home address, because it's enrolled with Medicare, that becomes a publicly available practice location and a publicly available address. So that's something to think about. With your commercial payers outside of Medicare and Medicaid, it really depends on their individual credentialing requirements and expectations. And there may be an ability to enroll that as a practice location that could go on the claim form without having it be published in like a provider directory. If you were to go to an Aetna or Blue Cross or Cigna United Humana website and look for your provider and find all of those locations that are enrolled or credentialed as practice locations to have that withheld. At the same time, even if it's not in a publicly available provider directory, if you've enrolled that location and it goes on the claim form, the patient still may see it through their explanation of benefits. So there's just a lot of unanswered questions there. And I would say those are very real concerns and considerations about having providers potentially home addresses made public that way.
Right. And that there was another question, and I'll just generalize it more specifically. If you've got clinicians that also work in a facility, but then may work from home, are they registering their home and each facility? That might require a little bit more thought, but kind of throwing that out there generally as well.
Yeah, exactly. So Medicare's expectation is that any location where they're rendering services from on a regular basis, that may be the clinic, and then they go to 2 hospitals. Each of those is a different practice location. And so you put that practice location on the claim form, and I'm picturing a paper form, but I think it's box either 32 or 33 down at the bottom, tells you exactly where the provider rendered that professional service from. And when we're talking about a telehealth service during the PHE, that has been their typical practice location, like the clinic or maybe their hospital-based provider. But if the provider's doing that remotely now, working from home, during the PHE, we haven't had to register that practice location to add it to the claim form as the service location where that particular service was rendered at that time. But after the PHE, we'll have to do that.
Thank you. We had one more question. I'll go ahead and ask this one, and then any more that come through about these changes, we'll hold off until the end of the webinar and we can address them after if needed. Do we know on mental health patients if those patients will still be able to have telehealth visits without ever having a face-to-face? I see.
All right, queuing up the next couple of slides here. That's a perfect transition. Let me hold that question because I've got that addressed in here, and I will respond to that one. Between that and the Ryan Hyde Act, those are probably the 2 most common questions I'm getting about this transition away from the public health flexibilities. So I'll make sure I get to that. Now, the next important block of time, I'm going to say it's actually 2 parts. I've got on this slide December 31st of 2023, but even before that, remember this time last year, the Consolidated Appropriations Act of 2022 said that there were certain flexibilities that would extend for 151 days after the PHE ends. And that was an act of Congress. That was a statute. So in the Medicare final rule for 2023 that was published in, I want to say November, Medicare said they would follow that for their payment policy purposes. They would follow that 151-day extension. So keep that in mind. That's actually going to come on the next slides with a new and different time frame. So I'm jumping ahead now to the things that will go away the end of the calendar year when the PHE ends, which it looks like will be December 31st of 2023. Now I'm going to see if I can possibly share my slides. Hopefully you see an Excel spreadsheet here. Did that work, Molly? Perfect. Okay. So this is the list of covered telehealth services from the Physician Fee Schedule Final Rule by Medicare for 2023. And if you'll look for each of the CPT codes, there are notes on when that service may fall off of the covered telehealth list. So we see some that are available through December 31st of 2023. If you're providing any of those services, as of right now, those will go away at the end of this calendar year and will no longer be allowed as covered telehealth services. Now, the deadline, I should have had this exact date because it's in the month of February and it would be coming up really soon if it hasn't already passed. The deadline to request telehealth services be added to the Medicare covered telehealth list is here in the first week or two in the month of February. And I'll get that exact date that we can send out. So if you're providing these services that may go away at the end of this calendar year, and you want those to continue to be available next year on January 1st, 2024, your practice should really consider submitting information to CMS. And you want to include what the code is, how it's provided, the safety, how you can protect against program integrity concerns. Those are the types of things that CMS is always looking at to see, how is this like other telehealth services? How is this like an in-person face-to-face visit? And how does that get rendered effectively in a telehealth type platform? Also on this list, you're going to see some of these services that can be rendered via audio only. I'll talk about those dates. And in just a minute, I'm going to talk about this list where it says they expire 151 days after the PHE ends, but that was released before December legislation that extended that time frame out further. So I'm going to come back to that spreadsheet in just a minute. So again, those codes, they're called Category 3 codes, but those are the group of codes that you see on the spreadsheet that will go away as covered telehealth services for Medicare at the end of this calendar year, unless they're added as permanent telehealth services through Medicare's rulemaking that starts in July with a proposed rule and that will get finalized usually October or November. Some billing pieces. Medicare instructed in the 2023 final rule to continue using the place of service code that describes where that service would have been rendered if it was in person, even if you're providing a telehealth service through December 31st of 2023. So what that does is potentially allow you to be paid at the higher non-facility rate through the end of this year. Let me give you an example of that. Before the PHE, our rule for reporting place of service for telehealth is that we use a 2-digit code 02 describing a telehealth service. That code 02 caused the claim to be paid at the lower facility rate. And the idea was, if you're rendering a telehealth service to an individual, you don't have the same overhead cost that you would have if the patient physically walked into the clinic, checked in, sat in the waiting room, was roomed by a nurse. You don't have those same administrative costs. So it was paid at a lower rate. During the PHE, we were instructed to use the place of service code where the service would have been rendered. And if it would have been rendered in a non-facility location, like a clinic, place of service 11, you could be getting paid the higher non-facility rate for that service. And that will go away at the end of this calendar year. And we will again report either 02 for a telehealth service or a new telehealth place of service code 10, which describes a telehealth visit to a patient who is at home. Virtual presence is a concept that has come about during the public health emergency that has given us flexibility on where providers are located when a telehealth service is rendered. So we often may have registered nurses who are providing telehealth services to patients and billing those under an advanced practice provider or a physician who's overall supervising and responsible for that service. Think of, in the context of an in-person visit, that may be a patient where a patient's coming in for a med check. Are you taking your medications? Are you having any symptoms? How's your blood pressure? Weights for patients with congestive heart failure. But that may be a visit with a nurse billed by an APP or by a physician. If you were to do something similar in the telehealth context, nurse, having a telehealth visit with the patient. The supervision requires direct level of supervision. And under Medicare's rules, that means in order to bill for that nurse telehealth visit under an APP or under a physician, there has to be that the two individuals, the person rendering the telehealth visit and the supervising provider, must be physically located in the same office suite where the supervising provider is immediately available to intervene. And during the PHE, Medicare said, no, that doesn't make a lot of sense in the telehealth context. And we may be able to have a provider who could intervene from home, even though that provider is in quarantine or symptomatic, but well enough to still intervene to provide services. Or we may have nurses who can work remotely now to deliver telehealth services, but they're not physically in the office suite where the supervising provider is, even though the provider could jump into that telehealth session if needed. So Medicare developed something called virtual presence as a way to satisfy direct supervision during the PHE and allow us to continue to bill those as incident to services under the name and number of the supervising provider. The concept of virtual presence, as of right now, is scheduled to go away December 31st of 2023, which means the provider rendering the telehealth service and the supervising, the billing provider, must again be physically located in the same office suite so that the supervising provider is immediately available in order to bill for that service. I'm going to put kind of an asterisk, or I guess I literally put an asterisk on this one, that while this is Medicare's intent, they sort of opened the door to say, we will revisit this in next year's rulemaking. So if you have adopted different work styles where that type of in the same physical office suite, immediately available level of direct supervision impairs access or may impair quality of care or other considerations, that will be really important and helpful to contribute to public comments to CMS this year, to give CMS a sense of how virtual presence is being used and whether to continue that policy or whether it will in fact end December 31st of 2023. Did I say 21st December? Let me say that again, December 31st of 2023. Okay, a couple of other, so we skipped over this 151-day extension, and I did that for a reason. Last March 21st, a Consolidated Appropriations Act was passed where Congress said certain pieces of telehealth flexibilities will continue to be available for 151 days after the public health emergency ends. I have no idea where 151 days came from. It was initially proposed in a bill to be 2 years, and what actually passed was 151 days. But it wasn't all telehealth flexibilities. It was only certain pieces. FQHCs and RHCs could continue to bill for telehealth services as distant site providers for 151 days after the PHE ended. Because prior to the PHE, FQHCs and RHCs were only eligible to be originating sites for telehealth, meaning where the patient was located while a telehealth service was provided by another distant site professional. So this act said that will continue for at least 5 months when the PHE ends. The act said that we would continue to make available any professional who is eligible to bill Medicare could be an eligible distant site provider of telehealth services, because prior to the PHE, only certain disciplines and licensures of professionals could serve as distant site providers. Physical therapy, speech therapy, occupational therapy, for example, could not act as distant site providers before the PHE. This act preserved that ability for at least 151 days when the PHE ends. The originating site where the patient is located during the PHE, we added a little bullet point that said the patient could be at home and there's no geographic restriction, meaning a rural health area or a healthcare provider shortage area. This act in March of last year actually expanded that even further and said when the PHE ends, anywhere in the US that the patient is located could be an eligible originating site. So not just the patient's home, it could be a retail clinic, it could be a library, it could be a school, it could be any number of places as long as the patient was still in the US. And I want to add that that doesn't mean we can ignore our state licensing rules, where we have to be generally licensed in the state where the patient was located. But for Medicare purposes, it was really broadening where the patient could be located and still potentially eligible to receive payment for a telehealth service. Services rendered as audio only. I'm going to flip back over to the spreadsheet really quickly. Those services that are eligible to be rendered as audio only as opposed to audio visual telecommunications technology could continue to be rendered as audio only for 151 days after the PHE ends. And this is where that 6-month in-person visit requirement comes into play. Last March, Congress said that pesky requirement that was passed saying if you are receiving or delivering, I should say, a telehealth service for mental or behavioral telehealth when a patient does not have substance use disorder and the patient is at home when the telehealth service is provided, that there has to be an initiating in-person visit in the 6 months preceding that first telehealth visit. Has caused a lot of problems and questions in the industry. That was put off for 151 days after the PHE ends. All of this to say, these pieces that would have continued for 151 days have now been extended through December 31st of 2024. So there is no more 151-day period. Anything that was a part of the 151-day period now goes out through December 31st of 2024. There is a little bit of a wrinkle in that. The wrinkle is that piece of federal legislation was passed in December right after the Medicare final rule was released. And Medicare's payment policy said 151 days. So as of right now, we have a statute saying through the end of 2024, we have Medicare policy saying 151 days. What I expect we will see at some point in the coming months is a technical correction from CMS or an interim rule clarifying that anything they said was 151 days, they will follow Congress's statute and extend those out through December 31st of 2024. So our regulations haven't caught up to the change in law yet. Now, the in-person visit requirement for mental behavioral telehealth services, if that requirement had ever gone into effect, I want to emphasize it is only for patients who do not have co-occurring substance use disorder. And it is only for patients seen at home. If the patient has co-occurring substance use disorder or substance use disorder is the reason for the visit, there was no in-person six-month in-person visit requirement. If the telehealth service would have been covered under normal pre-COVID telehealth rules, eligible distant site provider, an eligible originating site like a clinic, an FQHC, an RHC, rural geographic area, eligible telehealth service on the telehealth list, there was no 6-month initial visit requirement. It is only or was only when the only way that mental behavioral telehealth visit would have been covered is a result of expanded telehealth rules unique to mental behavioral telehealth services rendered to a patient at home. That before the PHE was not an option to render services to a patient at home. That's when the 6-month initial in-person visit requirement could have come into play. But before that act ever really was effectuated, COVID hit, we got a flexibility, and that requirement never really manifested yet. So the question has been, now that we know that will continue through December 31st of 2024, that flexibility, that waiver of the 6-month in-person visit requirement, when and if it ever would have come into effect. We had guidance in the 2023 Medicare policy that said, for those patients who have been receiving mental behavioral telehealth services at home without substance use disorder co-occurring, they will not have to have an initial in-person visit within 6 months of the first telehealth visit after that December 31st timeframe. They're kind of grandfathered in. They've been receiving those services. Now, new patients beginning to receive telehealth services in 2025, they would need that initial in-person visit within 6 months. I say that, but that particular requirement is on the board in about every telehealth bill that we see at the federal level. I would not be surprised if between now and December 31st of 2024, we may see legislation that eliminates that requirement entirely, so it never comes to fruition at all. But at the earliest, January 1st of 2025, for patients who had not been receiving mental behavioral telehealth prior to that date, is when that requirement would go into effect. Okay, a few other pieces that I said there was no 151-day time frame anymore, but this is one bucket that we'll be waiting for CMS guidance on whether Medicare will also extend these coding and billing changes through the end of the calendar year, through December 31st of 2024, or if they may stay with a 151-day time frame. We don't know yet. In the final rule for 2023, Medicare said modifier 95 is something that would continue to be used for a telehealth service for 151 days. The reason we have been using modifier 95 during the PHE is that's how we identified that a particular service was rendered via telehealth. We needed the modifier because normally we would identify claims by using place of service 02 for telehealth. But during the PHE, we haven't been doing that. We're using the place of service that would have been used had it been an in-person visit. So Medicare said, because they intended to switch back to place of service 2 when the PHE ends, that modifier 95 would be used for the same amount of time. So I expect we'll see guidance that because we're going to continue to cover place of service, where the place of service where it would have been rendered as an in-person visit, through the end of 2023, I also anticipate modifier 95 will continue to be used through the end of 2023. Effective January 1st of this year, a new modifier 93 is available, and that identifies when the telehealth service was rendered using audio-only technology as opposed to audio-visual. And because the use of audio-only technology is being considered on whether that should be a permanent modality for telehealth or whether that should be wound back for program integrity concerns and quality of care concerns, I anticipate that modifier is going to be used to help Medicare identify claims, pull claims, look at records to help advise on policy decisions on how long or whether audio only will continue to be available as a modality for telehealth permanently or in the long term. Supervising providers who are using that virtual presence flexibility to meet the direct supervision requirement should be now and should continue to use modifier FR if they're supervising through virtual presence through at least 151 days after the PHE ends, and I anticipate we're going to see guidance asking that continue through December 31st of 2023, although we haven't seen that rulemaking yet. So while the slide count was short, there's a lot of information for a 1 hour period. And Molly, I think we may have some questions that have come through, so I'll pause there to see if I can answer anything further.
We do. One question was, how do they submit a request for services to be added to the list, and what is the deadline or due dates? What would the timeline look like for that?
Perfect. There's a website on the CMS website. If you search for telehealth submissions, there's a portal where you can submit a request. I'll get the link to the portal and the exact deadline to submit those. Hopefully it hasn't passed. It's usually, I want to say February 10th, so it would be coming up really soon, but I'll get that exact date and the link that we can send out with the materials.
Thank you. I will sort of go off of that. With our webinar in March, on March 7th, we will be talking about some of these sources and resources, how to find some of this information as well. So be sure to put that one on your calendar, but we will be sending out the link for the submission for requests sooner than our March 7th timeline. The next question is, when discussing behavioral mental telehealth, does this reference who is providing the services, regardless of code type of service, or does this reference behavioral health billing codes only? For instance, health psychologists may provide behavioral mental health services by telehealth, but bill only under medical codes.
Okay, so I think the question is asking how we would identify when the services are eligible under this expanded telehealth coverage for mental behavioral health to patients at home. Is it by the code, that the procedure code, the CPT code that's being used, or how's that designated? It is by diagnosis code. So what Medicare would look for if the diagnosis on the claim is mental or behavioral telehealth, and there is no substance use disorder diagnosis code on the claim, and the patient was at home, so after the PHE, that would mean place of service 10 is being used. That's how the service would be identified as requiring an in-person visit within 6 months of the mental behavior telehealth service, when and if that requirement ever comes into fruition. So hopefully that answers how those would be identified.
John, was that appropriate?
Yeah, that was great. And thank you. Can I just clarify? So if a psychologist sees a patient and bills a code and the diagnosis used is Crohn's disease, because that is what they're seeing the patient for, and different issues related to management of that disease, that wouldn't fall under these regulations.
Yeah, okay, so that's a great question. You've got a discipline of a healthcare professional who would typically fall within the mental behavioral health disciplines, but the diagnosis code doesn't fall within the mental behavioral health chapter of ICD-10. The way Medicare has explained that is that it goes by diagnosis code, and they're not looking at the taxonomy classification or the specialty of the provider. So psychiatrist, psychologist, at least the way they're processing claims right now, they've advised it's the diagnosis code that will dictate and drive those that telehealth benefit.
Great, thank you. What modifiers should a rural health center or clinic use now for a non-mental health audio only telehealth today? 95 plus 93, 95 plus FQ.
Great, so I'm going to go back to a slide because I'm going to have to look at my notes. So an audio only visit, 93, is added regardless of the provider type when the telehealth service is rendered as audio only. RHCs and FQHCs used to use FQ, now they're going to use 93 for that service. I'll have to double check as between 95 and 93. I don't think both are required because it's sort of duplicative. 95 is identifying a telehealth service, so is 93. But let me double check on that to see if you would need both or just 93. And then if there is virtual presence supervision, you may also need to add the FR modifier.
And then is there any anticipated impact to asynchronous visits?
Asynchronous, meaning, so we've got a couple of options for asynchronous visits. We have virtual check-ins. We have submission of photographs or video recordings that could be evaluated. We have the electronic visit, which is kind of the patient portal communication visit service. Because those are not telehealth services, they don't fall under the telehealth benefit of Medicare. They're not impacted by the timeframes that we're talking about today. They have their own rules and requirements as non-face-to-face asynchronous services.
And then I did have a couple questions come in about the spreadsheet that you showed. Would we be able to provide kind of steps on how you find that?
Absolutely. And again, this will be one that I can include in the March session as well. When a lot of these resources that I pull up during our sessions, we've never stepped back for me to show you exactly where you go on the Medicare pages to find these. So I can absolutely talk through that quickly and then send that in a kind of a step-by-step for you, Molly. But you go to the CMS website, cms.gov, click on Medicare in the top left-hand corner of the screen. And you're going to scroll all the way down to the bottom and click on physicians under provider type. You'll go to PFS regulation notices. It's a link that you're going to find on the left, kind of towards the top of the screen. And then in the 2023 final rule, you're going to see a page with a ton of attachments, a ton of documents that you can pull up. If you do a Control F on that page and look for telehealth, you will get the 2023 list of covered telehealth services, and that's the spreadsheet that I had pulled up.
Okay, thank you. And we'll send that with our follow-up email. We have quite a few resources we'll need to pull for the follow-up to this webinar. So please be a little patient with us while we pull that stuff together and get it all sent out to you. We did have a couple more questions come in the chat, but in interest of time, we will have to take those down and get back to you on those. And if you do have questions, you can send them directly to our email, htrc@kumc.edu, and we will connect with Rochelle as needed, depending on what type of questions that you have. But again, please note, questions that came in just now, we will be getting back to you on those pretty quickly. And if you do have any more, please get back to us. So thank you once again, Rochelle. Always great information. Be on the lookout for us for March 7th. Where we're going to talk about these reimbursement resources to support telehealth programs, and it will include some of the things that came up today. So please be sure to join us for that. We are looking at April for another webinar date, and it may be dependent on some of these updates that Rochelle talked about. So please be on the lookout for that as well. Anything else, Rochelle? Any last minute thoughts? Be patient.
Yeah, right. As quickly as things happened in February and March and April of 2020, I think we're going to start to see the same, just in reverse order here in the next couple of months. So I'm sure there will be a lot of updates, and I'll try to keep Molly and HTRC posted so we can let everyone know if anything changes.
Well, thank you very much for joining us today, and please keep a lookout in your inbox for information coming from us. Thank you all.